Hello, everybody. Thank you for joining us this afternoon. So, thank you all very much for coming, and welcome to the GP Assistant course, the third cohort. So this is the third time we've done something similar. Unfortunately, it's the second time we've done it online, obviously because of COVID and things, and maybe we'll see if we get further cohorts whether we manage to meet up and do things in person. So we'll talk a little bit about the history of the GP assistant role, and what's happening elsewhere around the country and how we got to the position we're in at the moment. We'll talk a little bit about the outline of the course and how the course works, and also a little bit about the evaluation that we'll be hoping you, we'll need you guys to assist with both before the start of the course and also at the end of the course as well. We'll also do a quick demonstration of how the online portal or portfolio works, which is the website which you'll all get logins to, as will your GP mentors, and that's where you upload evidence of your learning, and where the GP mentors will then look at your evidence and assess competency. And we'll also talk about sharing details and creating a bit of a GP assistant community. It's certainly something that people have found very helpful in the past, and it's something that I think is really important going forwards. But we can talk about that, and that's not going to be an obligation, but certainly things that people have found really helpful in the past. So why did the GP assistant role come about? So this is a slide that we used in our very first launch event about 4 years ago. And it really came about because of the burden on GPs and clinical staff within primary care. So GPs were retiring earlier, either due to ill health or just choosing to take early retirement. Long waits for GP appointments, seeing lots of contacts throughout the day, and that administrative burden, really, death by admin, that people were feeling, and I think still are really. There's lots of challenges in primary care at the moment. So there's the traditional primary care roles of doctors and nurses, the shortages across all of primary care, and the King's Fund named workforce shortages as the single biggest threat to delivering the long-term plan. We've got a population that are getting older with lots of complex health problems. And I'm not going to get into politics, but there have been funding challenges for a long period of time in the NHS and especially in primary care. And I think some clinicians, some GPs are feeling burnt out, say retiring early, and that sort of feeling of drowning in administration and stuff, really. And then we've got COVID-19 as well, just to add into the mix. Of staff absence, often at short notice, the backlog of work that we probably felt a little bit last year and probably will continue to feel for a couple of years, long waiting times for secondary care referrals. And there are different ways of working now with more practices doing more via telephone and other methods of consulting, I guess. And so in some ways, the GP assistants that we're training now may work slightly differently to the GP assistants from the first cohort, or how we thought that the GP assistant role may look initially. So I guess with challenges come opportunities, and there's lots of new roles in practice. I'm sure in your surgeries, there's roles that are now there that maybe weren't 4 or 5 years ago. Certainly in our practice, we've got pharmacists, physio seeing patients within the practice. And there's many other roles that are working directly closer with primary care now. And I guess the question is, do these new roles address these challenges that we've just talked about? And often the answer from the literature is we just don't know yet, because they, by definition, they're new roles. But it seems right and it makes logical sense. And that's another reason why the evaluation is so important, because we need to create evidence to show that these new roles are helping. Because if they're not helping, then what's the point, really, I guess? And it's a really opportunity to change the way we work, to transform the makeup of our workforce, which is more fit for the future challenges, I guess. And I guess in some ways, we're trying to make sure that each member of staff is working towards the top of their license for the majority of time, and who's the most appropriate person within a practice setting to be doing which job, whatever task it might be. And are there things that we can move around to free up time from some of our clinicians who can be spent more time maybe with patients or whatever it might be. Okay. So GP assistant. So it's still an emerging role. There's still not a vast amount of qualified GP assistants around the country. And as I say, it was initially the administrative burden identified by GPs when considering early retirement. There were some really successful pilots in the Northwest, mainly qualitative feedback more than anything, doing a sort of mixed clinical and administrative role. And now there's expanded across the country, and there's 7 different regions, all using a mixed sort of clinical administrative role for the GP assistant course. London are slightly different and using purely administrative GP assistant course, but they're slightly different and slightly separate from the rest of the country. But there are common themes throughout that have been the case throughout all our cohorts, and certainly the vast majority around the country, in that all GP assistants, certainly in the Midlands, have been recruited from pre-existing staff, and all the learning and teaching has been done within your own practice. And there are real benefits to that. Sometimes in that you already know the people you're working with, they already know you, they know your capabilities, they know that you may be able to do more than you have been doing, and you've got the ability to do that. And also the nice thing about learning on the job is that you can bend and focus the training on, depending on how you see the role in the future, how it's going to fit within your practice, how you want it to work. And we'll talk a little bit about later about how you can get the best out of it and make it work better for your practice and for what you want in the future. And those talking about the importance of those early conversations with the practice and with your GPs as to how you see this role, not only how you see the training going, but also how you see the role once the training completes as well. So what are GP assistants? And I sometimes find this a really hard question to answer. I guess they're a hybrid general practice worker. I guess part personal assistant. Now that doesn't mean you're there to make the GP a cup of tea or whatever it might be, or answer their phone calls, but I guess there to assist the clinicians or whoever it might be with tasks and things, and part HCA as well with sort of the clinical skills. I know often the terms are confusing: personal assistant, physician associate, GP assistant. It is easy to get things confused. But I think it's important at this time to say as well that up to this point, a GP assistant in one practice may work very differently from a GP assistant in another practice. And although the course does train a sort of covers a competency framework covering a whole range of areas, in one practice a GP assistant might be more patient facing and more get involved with the clinical stuff, whereas in another area, in another practice, they might have more of an administrative focus. And that is between the GP assistant and the practice to work out how they see the role and how they want to work, though they need to be competent in all the areas of the course. So what can a GP assistant do? So there are the clinical HCA type roles, so blood tests, ECG, urinalysis. I think one of the really nice things about this is it adds significant amount of flexibility to the workforce, especially with COVID and short-term absence, people going off sick. If you need an ECG checking at 6 o'clock on a Friday night, there's an extra person who may be in the building who might be able to assist with that. I'm always on call on a Friday night in my practice, so I'm very aware of how much that might be, benefit people. And they can support the GP in different ways. As I say, anything I say doesn't necessarily mean you will be doing as a GP assistant, because it depends on how you want to work. But some practices might have we all know those patients who take 4 minutes to walk down the corridor, 3 minutes to take the coat off, 2 minutes to tell you about the dog. Then they tell you they've got abdominal pain, so they need to get on the couch to be examined, and then they get back up, and then they tell you another problem, and they need to get back on the couch. And for those patients, we know before we even call them into the room, we're looking at a 20, 25-minute appointment. Now, some practices may use GP assistants to get someone into a room, get the coat off, find out the main reasons why they're here, maybe check a blood pressure, or maybe check some basic observations if they're going to be necessary. And if they find out they're here with tummy pain or abdominal symptoms, they might even get them on the couch ready, so that when the GP comes in, they can focus on what's really important from the medical point of view, and actually save the GP some really important time there, while the GP may be in another room dealing with another patient or other work at the same time, using that time most efficiently, I guess. It might be that the GP is having a really busy day on call, has had to admit one person to hospital. He's waiting for a call back from one of the specialists at the hospital about some blood results. Is there somebody else who can be having those conversations with secondary care? Is there somebody who can be ordering some of those tests? Is there somebody who can be sorting out the letter that the patient's going to take with them to hospital, to take some of that stress away? Now, I know with COVID, it might be that we've gone away a little bit from having a waiting room full of patients all the time. But certainly helping manage workload on particularly busy days is something that they can help with, certainly. And then even some practices, they might even choose to have a GP assistant in the room, helping type notes, helping order tests there and then, alongside the GP. I'd say that's probably not the majority of GP assistants, but in some practices that might not really suit them. And then the administrative side of things as well. So talked about ordering tests, reviewing test coding, letters, completing routine sections of forms, that universal credit, insurance reports. These are often the things that the GPs work till 7:30 at night doing, because they've finished seeing the patients and they check the tray, and that's what's left in the tray really for insurance reports. And is there somebody else who can do the fact-filling parts of those forms? GP will still need to sort of check it, but that's going to be a lot quicker than trawling through the notes and things, and can certainly be time efficient there. So they're just a few of the things that GP assistants may be able to assist with in practice. Now, in terms of the national picture, so I've covered some of this already, but because of the success of the original pilots, again, predominantly qualitative feedback, because quantitative data can be quite tricky to get, especially if you're just looking at the start and the end of a course. And I guess it's tricky to see real change during that time. And also the fact that in the cohorts we've had so far, COVID's been a massive problem when trying to compare apples with pears in terms of the start and at the end of a cohort, where obviously things have been changing so quickly in terms of how long patients are waiting for appointments and all those things. So we started off with 40 learners across 7 different regions, and we were charged with running this for the Midlands region, and all different regions feedback centrally to Health Education England. And we've now in the Midlands completed 2 cohorts. We've got over 60 GP assistants trained within the Midlands region, and we've got up to 60 learners on this course as well. So it is a growing role, certainly. So how will this pilot run? So this, I would think of this as a 6-month course. So when we first did this, it was a 6-month course. And we'll try and start it towards the end of this month, and get you all logged on, get login details, and those for your GP mentors as well, so you're ready to get going. And we'll aim for a end date end of September 2022. We will allow an extra 3 months at the end of that. So people, because primary care is busy, because things happen, life happens, primary care happens, and people go sick. There might be weeks where you don't get a chance to have any protected time if you're covering for someone else, different personal circumstances. So we will allow up to 9 months but we won't be able to extend training beyond that. And so I would really think about trying to get everything done within that 6-month period and leave that sort of 3 months as a buffer. And actually, if you manage to get everything done by the end of September, fantastic. And that will probably mean that the certificates arrive earlier for you as well. There are 5 different domains that we cover. So administration, clinical skills, communication, managing health records, and the care certificates. And hopefully this will become a little bit more clear when I show you the online sort of demonstration later. But each of those domains will have different competencies within them. And basically the main way of assessing this course is you provide evidence through reflection or through sessions you've had with the GP or practice manager or whoever it may be, and you provide evidence of your learning, and your GP mentor or your secondary mentor goes in and assesses your evidence and decides whether you're competent or not. We'll talk a little bit about the secondary mentor in a little while, and hopefully this will all become more clear. As I say, don't worry too much about the detail at this point, because it should all become more clear as we go along. The GP mentor stating that you're competent is the main part of the verification in this. So if your GP mentor thinks you're competent in these areas and you provided evidence to show that, then there's no exam, there's no test. We don't do any external testing or anything like that at all. Because if your GP mentor thinks you're competent in these areas, then that is satisfactory. We will, as the training hub, we review 10% of completed portfolios. So we will look at the 10% of those and check that, yes, we agree that the evidence is there. And then we forward all the portfolios on to Chester University, who review a further 25%. And assuming there are no major issues, then that is the verification done and the certificate will be on its way. In the latest cohort we've had, we've got some learning from Chester University, which I'll share with you in a little while, which is really useful. And sort of tips and challenges and things they've got from looking at portfolios, which will be really helpful. Good. So time commitments. So we think this course probably needs a day a week of dedicated time to it. Now, all of you will come from slightly different backgrounds. Some of you may be HCAs, some of you may be receptionists, some of you may be administrators, some of you will say we'll have a range of different people starting this course. And so you'll all have different, some areas where you may already be competent and you just need to provide a little bit of evidence in that area. We normally think half a day a week of sort of learning, whether that be a tutorial with the GP, whether that be sitting in with the GP, whether that be with the HCA, whether that be with one of the nursing staff, whether that be with the practice manager or one of the administrators, depending on what competency it is you're trying to achieve. Or it might even be an online course or an online learning thing or doing some reading online. And then we'd normally say you need about half a day to write up what you've learned, to write up and reflect on your learning. That might be maybe do some further reading and to update your portfolio with evidence showing that you're competent in those areas or showing that you're gaining competency in those areas. I think one of the problems we've had in the past is that practices maybe haven't really understood how the time is needed to protect. And actually, if you're trying to do this in your own time at nights and weekends, it's going to be really tough. And so you do really need to have those open, honest conversations with your practice team, I guess, and work out how you're going to manage to fit this in. We don't audit it. We don't check that you're having a day a week. And we know that every practice works in a slightly different way. But it's really important that you've got the support of your practice and the support of your GPs to allow you to complete this course, because if you're trying to fit it all in your own time, it's a very big ask, and evidence from the previous cohort shows us that they're the people who are more likely to struggle and maybe have to withdraw from the course at some point. In terms of evaluation, I'll hand you over to Sarah, actually, who can share her pearls of wisdom, because she's our evaluation lead and has done some fantastic work on the first couple of cohorts. I'll hand over to you, Sarah.
Hi, everyone. Am I off mute now? Good. So we do try as hard as we can, as far as we can, to make this easy for people. What we've done in the past is we've had a survey at baseline, which asks you your hopes for the role, what you're hoping to achieve. We ask the GP mentors how much time they spend on admin, how much time they think that they can gain, and how much they what they're hoping for the role as well, both clinically and administratively. That usually takes somewhere around about 8 or 9 minutes to fill in. The survey that we developed has been adopted as the national template now, so we're quite pleased with that. We also try to interview some of you at the end. So there'll be a survey, another survey goes out at the end when you've finished. We try to interview you, because I think with this being such a new role, it's been very, very important to us to actually talk to people. And a lot of the most important lessons we've picked up would be hard to pick up from a literal tick box. So the funding for this is dependent on engaging with at least the surveys. The interviews, we appreciate, are harder for people to fit in, but we're also very open to feedback throughout the process. And I don't think, I wouldn't want anyone sitting on their, if anyone was unhappy, I wouldn't want anyone sitting on their unhappiness for 9 months and then telling us in a year's time. I am semi-independent. I don't work directly for any of your GPs, and I'm an associate of NATH. So I have no ego invested in this whatsoever, and I'm perfectly prepared to hear hard lessons. Shall I talk a bit about what we found out, David, or are you going to pick that up in a minute?
No, I'm happy for you to share what you found from the evaluation, then I can...
So our previous evaluations, I think the first thing to say is I can be super enthusiastic at this point. We have been consistently impressed by how open people are to telling us things, by the enthusiasm and passion of some of the workers we've spoken to. We've had some brilliant, and again, most of this is qualitative, but we've had some brilliant cases where people have been able to pick up a phlebotomy clinic, which in real terms has meant that patients have got their bloods a week faster because someone's gone out sick and the alternative would have been cancelled. So we've had people who've been able to pick up clinics and keep them running. We've had somebody in the first cohort who was able to pick up a lot of the practice managers' work when they went out sick, which from the practice's point of view meant that things didn't collapse. Referrals kept running, the business kept running. Everyone was much less stressed. But actually, if you think about it from the practice manager's point of view, they weren't worried sick that everything was collapsing when they were away. And we've been consistently really happy with how the majority, although of course never everyone, has been really able to pick up new skills and to really help their practices. The one word that comes out when we talk to the GP mentors about what's changed for your GPAs has been confidence. The other thing I think that comes out that we can be positive about is that a lot of our GPAs have already got 5-10 years experience in the NHS. And with that comes wisdom, which I don't think we talk about often enough in the NHS. A lot of you have an absolute wealth of practical experience of dealing with human beings and difficult situations and working problems out. With that in mind, I think one of the first things I would like to emphasize as things we've learned is that if you are able to engage with your fellow GPAs, and if you are able to engage with things like WhatsApp groups, there is an awful lot that you can learn from each other. And there's an awful lot, I think, that the health professionals can learn from you in terms of real world experience too, if they're open to that. So use your peer networks if you can. The next thing we've learned that David's alluded to is just the sheer difficulty of getting into getting people supervision. There's still a pandemic. GPs were busy before the pandemic bit. And with my evaluation hat off and my general manager hat on, I would like to really encourage people to try and book supervision sessions, get them formally in diaries. And it doesn't have to always be with your GP mentor. If there's something that you think that a nurse could help you with or an HCA could help you with that's specific to their skill set, but get the appointments in diaries. It's no good saying, oh, I'll grab you. And a lot of people are tempted to say, oh, I'll grab you. It doesn't happen. And it's an awful lot easier to reschedule a meeting that's been made than it is to get a new one in the first place, particularly if you've got something that comes up that you really want to talk about. The other thing, I'm just checking my notes. I think that's important, is to emphasize this idea of space and time. I think even before the pandemic hit, we were picking up problems that people, it's not just the time to study, but things like if you've got one laptop at home and somebody in your family has borrowed it to look at Pokemons, which happens a lot in my household, wrestling it back off them and finding a quiet corner to study in can be an issue. So I'd like to emphasize what David said about really negotiating that protected time. And I think that's something that your GP mentors should also be very, very aware of, is you need time, equipment and space to study in. Doing it at 10 at night when you finally manage to wrestle the laptop back off the Pokemons can be certainly a serious issue in my household. The last thing I think that we've learned that I think is really worth talking about is the idea of what the role is going to be when you're finished, which again, David's alluded to that. We have found that GPs and GPAs sometimes have different expectations for what the role is. And we've also found quite a lot of people who get to the end of their training and then you ask them, well, what are you going to do now? And we find that the practice has not yet discussed what the role is going to look like. Now, I think that's fair enough because this is an emerging role, and also because there was a pandemic and being absolute cast iron certain about things has been extremely hard. But I also think it's worth encouraging people to have conversations early with the practice, with your GP mentors, with the partners, with nurses, because the people who've been the most positive and who've had the best experience are people who've been able to say, and I'm going to be allowed to do this clinic, or I've been given responsibility for this particular administrative task. It's going to be my thing now that I do the insurance forms, or it's going to be my thing now that I do this sort of checkup. People who are happiest are people who know the difference they're making. And whilst I don't expect that most GP mentors would be able to identify that on day one, I would hope that by month 6, they're in a position to start having those conversations with you and start planning for it. That's not a requirement of the course, and it's nothing that we are going to take an active hand in forcing, but it does seem to map quite closely onto who's happiest. I think that's the big ones, David.
Yeah, thank you, Sarah. Good. And yes, well, I don't think I've got anything more to add from what Sarah said, but yes, thank you for that, Sarah. So there's a new addition to this cohort, and going forwards, people can appoint a secondary mentor, or we'll be asking people to appoint a secondary mentor. And this is someone who can assess the non-clinical domains. Ultimately, it will still be the GP mentor who's has overall responsibility for the portfolio as a whole and assessing whether someone's overall competent. But it can certainly save some time having a secondary mentor who can assess and feed back on some of the evidence and assess competency in the non-clinical areas. I know a lot of people have already replied to me with details. If you haven't done yet, then if you could send details of a secondary mentor, it can be any appropriate member of staff. That might be a practice manager, that might be a administrator, that might be a nurse or a HCA. Think about someone who you're going to probably work closely with as well. And sometimes, I think we've found in the past, sometimes there has been a bit of a distance between sort of GP assistants when they're training and the GP mentors. Sometimes they've worked really well together, but sometimes there has been a little bit of distance where you might sort of touch base every 3-4 months and they might not really have a close eye on what's going on with the course. Whereas actually the secondary mentor is an opportunity to have someone who you can work maybe even a little bit closer with than the GP mentor. So they're not there to replace, but they're there to assist the GP mentor and also assist you as an extra, I guess, a person who can support you if you don't know where to go or looking for advice on something. So I guess I know we've covered a lot of these, so some of this will be duplication. But it's, as I said, it's important to think about how this is going to work in your practice, both during the training and after the course. One area that we found sort of bottlenecks in the past is phlebotomy. So some people will already know how to do phlebotomy, in which case you can probably ignore me. Others will think, well, that's quite a big thing to do. I'm going to leave that for a while, and think about it early. If you've got someone in your practice who can teach you to do phlebotomy, teach you to take bloods, then fantastic, that's fine. You don't need to go on a separate course, anything like that. And if there's people within your practice or practices nearby who would be happy to teach you, then that is absolutely fine. We're not training phlebotomists. We're not training necessarily experts in phlebotomy, but you need to be competent or able to take bloods, I guess. If there isn't someone in your practice, if it's something that you feel like you would struggle to do, then you're more than welcome to apply for there are phlebotomy courses in every sort of locality on a relatively regular basis, but it's probably worth thinking about it early so that that's something you can get booked onto. Say each practice gets a training grant of funding for this course on successful completion, and it might well come out of that. So just have a thought about how you might want to achieve that. And if you're really struggling, you don't know where to go, or if you've got a circumstance that's unique to yourself, then do feel free to get in touch with me. Say, think about where to get support from, whether that be your secondary mentor, your GP mentor, from each other. Say, we'll talk about the options of setting up sort of WhatsApp groups or email chains where, and I know in the past they've been really successful and really helpful. We'll also be having drop-in sessions, so once a month, to troubleshoot if there's any problems, and we'll try and rotate the days we have those on as well, just because I think last year we did it every first Wednesday of every month, whereas if you work on a Wednesday and you can't attend, then it's not much use to you. So we'll try and rotate it around, and again, they've been well received in the past as well. Think about how much evidence is needed. I say we've got a slide from the University of Chester in a little while. It's about the quality of evidence rather than the quantity of evidence. Copying, pasting reams and reams of Wikipedia on blood vessels and things probably doesn't show much evidence of competency, whereas actually some personal reflection on some teaching or some reading you've had is a lot more useful. And we'll talk a little bit about reflection as well. And if there are problems, as I say, we really are friendly. I've spoken to about I think 20 of you already, and I'll be aiming to speak to everybody certainly by the end of April, by the end of the first month of the course, just to touch base, to put I guess to make it clear that we're very open, and if there are problems from either GP assistants, GP mentors, practice managers, get in touch. We're more than happy to answer queries, point you in the right direction. If we don't know the answer, we can find out, or we can point you in the right direction. So do feel free to get in touch with us if there are problems. Think about, if it's problem specific to your practice, think about, can you speak to your GP mentor? Can you speak to your practice manager? But if there are problems that you're really struggling with, then do get in touch with us. I'm more than happy to be contacted. Don't worry about doing so. So in terms of what you'll receive to help support you, so all GP assistant learners will receive a sort of a guidebook really, and a document that sort of helps discuss how to provide evidence. And GP mentors will also receive a supporting document via email, and that will come out in the next couple of weeks to you all, with tips and advice on how to meet competencies and things as well. So use that, read that, and it should prove helpful for you. With regards to the actual online portfolio, the system is run by Cisco, and they're a really helpful team there as well. So if there are technical problems in terms of, I've uploaded something but I don't know where it's gone, or how do I upload evidence, then if there's technical issues, then speak to them directly. We'll also be emailing out a sort of guide on how to use the portal, and there'll also be this as well. Yes, Sarah.
Just had a question on the chat that I'm not sure of the answer to about, can a phlebotomist surgery train another person to take blood, or does it need to be a proper phlebotomy course?
No, so certainly in previous cohorts, we've had people be trained up by in-house staff. There's certainly no obligation to go on an external course. Whether you want to use sort of formal checklists which can be found online in terms of ways of teaching and showing competency in phlebotomy, but there's certainly certainly there's no obligation to go on a separate course, and if there's somebody in your practice who's happy to teach you up and train you and feels able to do that, then that's certainly fine by us. So yes, so as I said, so supporting each other, and as I said, we are happy to be contacted. So this is the slide from the University of Chester. So they presented this slide at one of our sort of national meetups where all the different regions get together. And they came up with this slide after reviewing portfolios from GP assistants from all different regions in the country. And I think this is a slide that you'll have access to because you'll have this recording. So it's just worth thinking about. So some of the really things they liked about the portfolios were the variety of evidence. That might be reflective pieces, witness statements, videos, pictures, really good evidence of team working within the, from whether that be different people within the practice sort of providing evidence and working together on the course. And the power of communication between the mentor and the learner as well. So they really found that when there's constructive feedback given about some work and about some evidence, then that clearly improves the experience of the learners and also the quality of the evidence as well. There were some challenges, and I guess these are things to be really aware of. So if you're uploading evidence of clinical, so patients and things, or if you're sending screenshots of, say, System 1 or EMIS or whatever it might be, just be really careful to make sure it's all anonymized for data protection purposes, and also plagiarism. So I think there were episodes or times where, say, things were copy and pasted from websites, which without references or without crediting the original source. So just be aware of that. And as I say, copying and pasting large reams of text from elsewhere is probably less useful evidence than a shorter reflection on what you've understood from reading that, and what you've learned from it. I say copy and pasting, and also just making sure that you're looking at relevant articles. So sometimes guidelines from America or from other areas in the world were sort of cited rather than being relevant to working in the NHS. And as I say, sometimes certificates, online learning, those sorts of things can be really good evidence, but actually the certificate themselves probably isn't great. It's more a sort of and I'm happy for people to upload certificates, obviously, but then actually a short reflection on what actually you learned, rather than that, is more useful as well to accompany that than just posting a certificate, because that probably really tells me you've clicked through some slides on, we've all sort of clicked through slides on online learning courses and things, whereas actually some reflection on what that taught you and how that will impact your future practice, or how that will impact how you work in the future, is probably a lot more useful. Yes, and there was some comments as well about the sort of quality of feedback from mentors, sort of very non-specific. So yeah, the feedback is important that you receive as well. I'm not going to go through all of this now in the interest of time, but this slide will be there for you. Make good use of the Cisco platform. It is really good, and it can take some time to navigate, but if you get used to it and play around with it, then hopefully you'll get some good use out of it. And I think the focus on quality rather than quantity, and I know we've mentioned about reflection, that really is important going forwards and things. And what do we mean by reflection? So we sometimes use this sort of what, so what, and now what. So what actually happened? We had a tutorial on let's say blood vessels and anatomy of blood vessels. So what? So what did you learn? So why does it matter? Because then actually when you go to take blood, you might know the difference, be able to identify the difference between a vein and an artery, and how to tell the difference clinically. And now what? Well, now I'm going to put that into practice. So when I next see a patient, I'm going to feel, when I'm assessing whether it is a vein or an artery, can I feel a pulse? And that might help you going forwards. And actually, if you sometimes use that what, so what, now what as a basis for your reflections, that can sometimes be helpful. I say that you'll get guides with a lot more useful and insightful information than that, and probably a better example as well. But hopefully that gives you an idea when we talk about reflection and things. And for some of you, it'll be second nature and it's something you've done over a long period of time. For some people, it might be a slightly newer concept, but it's a really good way of providing evidence of competency. So now I'm going to try and demonstrate the online portfolio. And I'm going to try and do it from initially the GP assistant, so as the learner, and then I will try and do it as if I was the GP mentor assessing the evidence. So this is the front page of the platform. So I'm going to be as the GP learner is going to be Timothy Smith. I'm going to log in as him. So it will look slightly different just because Timothy Smith, this is his third course that he's undertaking. So if we go to my program, so as I say, for you guys, this will just show there'll only be one of these courses here where I'd say he's done the first, second and third cohorts and he's not completed any by the looks of things. So very basically, the grey bits, these are the 5 domains: administration, managing health records, communication, clinical and care. So if it's grey, it means it's not yet been started. If it's blue, it means some evidence has started being uploaded. And when it was all completed and assessed by the GP, it will be green, and that shows it's fully completed.
Sorry to interrupt. I can't see your screen.
Oh, is that?
No, nor can I.
Okay, let me have a quick.
Yeah, that's just, the chat's just moved as well. There we are.
I apologize. Let me try and share something.
There, that's it.
Is that it? Okay, so you haven't missed anything exciting so far. Apologies for that. So as I say, once you log in and you go to my program on the left, then you see this screen. So this is GP Assistant 3. This is the course we're looking at. So the 5 domains: administration, managing health records, communication, clinical and care certificates. The blue bits show that he started uploading some evidence. The grey bits are bits that haven't yet been started because he's only at the very start of his course. And once it's all completed, once a domain is signed off and assessed by the GP mentor as competent, it will appear as green. So you know you've finished the course when everything is looking green. So let's go into this area. So here is, so you can see at the top, he says he started 5% of his course. So he's done 5% of the course. GP mentor has assessed 3% of the course. An expected bar is based on his start date of the 25th of February and his end date of 30th of September. So he should have started 8%. Now, that's something to have in the back of your mind. It's not something you have to keep up with, or we won't be chasing people, but it's worth keeping an eye on that expected bar, because it just tells you whether maybe you are falling slightly behind in things. And although we're not chasing people to say you need to keep up to date, you need to have done 10% by this date and things, if we can see after 6 to 8 weeks that no evidence has been uploaded or people haven't logged in, then we will be giving you phone calls, not to tell you off, just to touch base and make sure there aren't any problems, see if there's anything we can do. And sometimes it might be that people are uploading or doing lots of evidence on Microsoft Word and storing all that to upload at a later date, which is okay. But it might just be that we try and contact you for that conversation just to make sure there's no problems that we want to identify early. So if you scroll down, so all these domains, so admin, managing health records, communication, clinical and care. And within each domain, there's different competencies that you can see. As I say, the blue bits mean that domain has been started. And so let's just pick, let's say we're today going to upload some evidence in the clinical folder. So let's have a look in clinical 9. It's a random selection. So if you clicked on the link under where it says resource, that would open up the competency framework for you, so you could see exactly what competencies you need to achieve this area. I'm not going to do that now because I don't think it will open on this right screen and things, and it's going to confuse things further. So in terms of how you upload evidence. So if you go to Evidence Wizard, it's probably the easiest way. Now, there's two ways of uploading evidence. You can either write your evidence in, say, a Word document, or if you've got a certificate or whatever it might be, you might want to upload the evidence. Has the Evidence Wizard popped up for people by any chance? Has there been a pop-up screen?
Can't see that. No pop-up screen.
Let me show you, just because I think that will be useful actually. So it will pop up like this.
There we are.
See that? So it'll say upload evidence or create evidence. So if you're going to upload evidence, you would go here, you would browse for files that you might say uploading a document, and then you would put some details in here. So you might write reflection on tutorial. And then you might describe there, upload some evidence. If the bulk of that's already in the Word document, you don't need to duplicate things, but it might just be a description of the thing you have uploaded, or it might be that the Word document or the whatever document is you've uploaded is a certificate, and you might want to put some sort of reflection on it there. Then you can specify, I'll just so it tells me, it doesn't tell me I've not completed something, and you can decide what type of evidence that is. So whether that be a professional discussion and some reflection, and you can cross-reference that piece of evidence to different areas. So we said we were doing let's say that piece of evidence I've uploaded can be used to tick out of the clinical for, so be able to ensure that environments and resources are ready for their next intended use. So we can say, yeah, my piece of evidence shows it's appropriate for these 4 parts of that competency, maybe not 4.5 or 4.6, 4.7 and 4.8 as well. And then once you are happy, you've ticked all those competency areas that you think that piece of evidence shows or shows evidence towards. It tells me I'm not actually uploaded anything. Let's upload something. So once you've uploaded something and filled all those in, you can save your evidence. And then I'll share my original screen again. So now you can see that's gone up to 6% at the top rather than 5% because you've uploaded some evidence. And you can say, yeah, so that will automatically link to those areas. And then when your GP mentor goes in, he will be able to assess that. So let's just have a quick look at that. So if we went to course again, if you go down now to clinical, which is now blue, which was grey before because you've started it, and you've provided evidence in here, and you've uploaded some documents, and the little blue star tells you that that's the area that you've started. And so as the module, you've now done 4% of the module, but it's still showing as completed 0 because your GP mentor hasn't yet gone in to assess that. So let's log out of here for a second. And log in as the GP mentor for Timothy Smith. And we can see what they see. So if they go to learners now, Tim is a test learner. So if you're the GP mentor, you'll find your GP assistant learner. So if you're a GP mentor with more than one, there'll be more than one name there. And you can see again, a very similar screen. And there's a couple of different ways you can assess evidence. So one is going into the evidence box specifically and looking at all the different pieces of evidence that have been uploaded. And the one we've just done is this number 4, reflection on tutorial. So if you wanted to review that evidence, you can click on this sign here, again, I know that's going to come up in a different screen. So let me stop sharing again. Sorry about this, a bit back and forwards. So it would come up in a box like this, where you might give some feedback. So good, reflection. I'm sure the feedback that the GP mentors give will be better than that demonstration. But if you agree with that, then you can save that, and that feedback will go back to the GP assistant learner. And then let's go back to the screen. So then we can see that evidence has been reviewed. And I guess evidence being reviewed is one thing, but then it's actually agreeing whether it shows somebody is competent. So if we go down to clinical, the clinical 4 it was. And as I say, Tim thought his piece of evidence showed he was competent in all these different areas: 4.1, 4.2, 4.3, 4.4, 4.7, and 4.8. Now, if as the GP mentor I agree, I put ticks in these boxes and can save that, and that will then, that completed bar will move up. If I'm not quite sure, then you can not, and you can send the evidence back to the GP assistant and say, don't worry about taking all this in, because there will be guides and other demonstrations available as well. So I've saved all that. That's why the completed bar here is, you can see, it's gone from 3% to 5% because it's been assessed as competent. And that's probably as pretty much as I'm gonna show you today in terms of the online portfolio. I'm sure there will be questions about that. As I say, you will get guidebooks and other things as well. And this, you'll have a recording of this. So if I've gone through that quite quickly, I know that you will be able to go back and do it slowly. I'm no expert at the online portfolio. I pretty much only ever use it to review some portfolios at the end, but also to do these demonstrations. And if there are challenges with using the portfolio, the team at Cisco are fantastic in supporting people as well. So don't worry about this sort of navigating now. That shouldn't be a big barrier to completing this. Okay, so I guess we're on to the final sort of thoughts now, and then we'll have some time for questions at the end. So we're all still learning. So it's still, even though this is the 3rd cohort, it's still new for us. I don't think anyone has perfected how to run this GP assistant course, or exactly how the future will look in terms of GP assistants. So we don't have all the answers, but nobody does. But we can certainly try and find the answers for you, or we can try and help and assist you. Our only aim is to try and get qualified GP assistants who can then support their practices and improve primary care for people. Support each other with WhatsApp groups. So once we get the course started, I'll send an email around to all GP assistants asking if people want to share their numbers for a WhatsApp group, and if somebody would set that up. And I'll also make sure I send an email out to everyone, so everybody's got an email chain that they're welcome to use if they want to. Try not to fall too far behind. Now, that's not saying 1st of April you need to be sat there doing work straight away, but certainly I wouldn't think I've got 6 months to do this, and 9 months potentially if I need to extend till Christmas. So I don't need to do anything for those 2-3 months. And probably the most important things you can do in the first 2-3 weeks are having those important conversations, speaking to your GP mentor, speaking to your practice, trying to make a plan really as to how you're going to achieve the competencies, and then making a start. And if you break it up into little week by week components, it really is really achievable within that 6-month time frame. And as I say, if you're struggling, shout, tell us. We're here to help, we're here to support you, and we'll do everything we can to try and get as many of you to the end of this course as possible. So that's my email address at the top. I'm happy for people to contact me directly. I think if there are questions specific to the course, you're probably better to contact me directly, because otherwise it will just go to the NATH Alliance inbox and will ultimately come to me anyway. So feel free to contact me. If I haven't contacted you, I know I've spoken to say about 20 of you. I'll be touching base with all of you at some point before the end of April. And following in the next week or two, there'll probably be further emails requesting final details so we can get everyone logged on and set up with the portfolio and things. If there's more administrative things, alliance.hub1@nhs.net is our email address, whether that be for form filling and details about those things. Are there any questions? I'm going to stop sharing my screen now and open it up to any questions that people have. People are either happy to ask in the chat, or if people want to turn microphone on, I'm more than happy either way. So I can see in the chat. So yes, Daria, you will all get Cisco logins, and you'll all get supporting documents. We'll send all that across, hopefully by the end of this month, certainly. Bridie says, can you evidence something that you've done in the past? Yes, absolutely. So as I said, some people on here will be HCAs, some people will have other skills from previous jobs. We've got a wide range of different people on this course and different backgrounds. So yes, just you don't have to relearn things just for the sake of it. Again, it might be that if you're a HCA and you already do bloods or already do these clinical skills, then it might be worth entering a short piece, reflecting, saying, I do this as part of my daily job. I've done it for however long, and a bit of a reflection just to show evidence of competency, but you certainly don't need to start doing things, start relearning and retraining, if that makes sense. How much mentor time is needed per week realistically? So a week, I think that's a tricky question to ask because it depends on, I guess, what competencies are being asked. I think the majority of the GP mentor time for previous cohorts has probably come in the latter half, where it's about assessing evidence and things, and it's about setting up the how much support and who's the best people to support the GP assistants throughout their training, whether that be certain competencies might be better taught by HCAs or nurses or practice managers. So it depends on which competency it is, and actually mentor time per week realistically, I would probably say an hour or two. It may be slightly more towards the end in terms of assessing, but certainly no more than that, I wouldn't think. And I think that's why if you set things up and have good discussions about how best to achieve competencies early on, then that's going to make things easier for you.
I think that's a really important point. I think the two really important points of this does not all have to be the GP mentor. There will be other people in the practice who have brilliant skills in other areas that can take on some of the supervision, certainly. And the other thing is that little and often works an awful lot better than getting to the last month and trying to do it all then.
Thank you, Sarah. So Katie's mentioned that we don't take bloods in our practice, so would we still need to find some training? So we have had people who found that challenging in the past, Nicola, in terms of, Katie, in terms of people have often said, why do I need to learn bloods? I'm never going to take bloods. We don't do bloods in our practice, and it can feel a little bit irrelevant or wasted time. I think the nice thing is because it's a certified role, and because you get university credits, then it has to be standardized across the whole group. So it probably is something that you might need to look at, either asking local practices if they can support you, or if there's any practices in your area who would be happy to train you. But equally, if not, there are lots of courses available, sort of PCDC courses and things. And if you're struggling, I can help try and put you in the right direction of things. In order to be signed off as a GP assistant, fully qualified GP assistant, it probably is something that we need to get you doing. But if there are problems, Katie, and say, have a chat with your people in your practice, and if there's problems, let us know. Nicola's asked, apart from tutorials with mentor and in-house learning, is all the other learning self-directed, or are there webinars? So we don't put on any training ourselves. So a lot of the training is done. It might not be formal training, it might be sitting in, it might be online sort of courses and things as well. It depends on what competencies are being achieved. It might be reading online, or it might be reading some guidelines in your practice. It might be looking up or sitting for a morning with a practice manager doing some work and things. And so there are no specific webinars that we put on. There might be some relevant online learning courses that you can find out there if they show competency in certain areas. And the tutor guide, the guide that we send you will have some guidance to that as well, but we don't put on any separate training.
And also, I mean, it's worth saying as well, any conversation you have is potentially something you can reflect on. If you have a chat in the corridor and an HCA stops you and says, well, I think you did that job really, really well, but next time I find it easier if, that conversation is learning, and you can evidence that.
Yeah, absolutely.
And in particular, I think that sort of thing is, it doesn't have to be an essay. It doesn't have to be a massively detailed piece of work, but that is realistically how we do a lot of our learning.
Bridie's asked, the amount of evidence is dependent on the reflection, so small amount or large written reflections. So I think you're right in that different competencies and different things will need a different amount of evidence providing. And there'll be certain bits of evidence that you provide that achieve more than one competency or show evidence in more than one area. So if you were to do a morning looking at a few different things with a practice manager, you're going to achieve lots of different competencies in that area, or certainly evidence towards those competencies. So you're right in that not everything needs the same amount of reflection as others. And I hope that answers the question you're asking, Bridie. And Jenny asks, do we do any specific training such as correspondence coding? So Jenny, I'm not exactly sure what correspondence coding is, to be honest. So that probably tells me it's too specific for me. So I think one of the first things for you guys to do will be have a look at the competency framework. So when you first look at it, I think it might be a little bit daunting. It might seem a bit daunting because there's lots of different areas, and it might seem very wordy. But just remember when you're doing that one piece of evidence might achieve multiple competencies, or a lot of it can be done as a group, if that makes sense. So but I think having a look at the competency framework and trying to get your head around it and working out for you individually where the challenges are going to be, because for some of you the challenges will be with the administrative side, for some of you the challenges will be with the clinical side, and working out really where you need to, I guess, devote your time. And also with that, depending on how you're going to work as a GP assistant after the training, or how you're going to work in your practice, will depend on where you may want to focus the majority of your time, because that's really what matters. In that, if you need to be able to be ready to do the role that you and your practice have sort of agreed on. And so although all the competencies need to be met, if you know you're going to be in with a GP or seeing patients face-to-face, prepping them for the GP to see them afterwards, and that might be where you choose to focus most of your learning time. Whereas if you know you're going to be mainly focused on the administrative side, again, that might be where your focus is. So just have a think about how you try and do that and things. And yeah, certainly, Shelley, there is coding. I think coding, I'm pretty sure coding is part of the competency framework. Off the top of my head, I don't know it off the top of my completely, to be honest, but I say we'll send that all out to you again in the next week or two and have some time looking through that. And Tracy's asked, are we allowed to mentor each other? There are 3 of us from the same practice on the course. So you could certainly assist each other and help each other, Tracy. I think in terms of being a secondary mentor to each other, it might be considered slight conflict of interest, being completely honest. Certainly one GP mentor can be a mentor to more than one person. But I think being a secondary mentor for somebody else on the course, I'm not sure that would be appropriate. But certainly you could have all the same secondary mentor if you wanted. So, and you can, it is the nice thing. So there will be some practices where there's more than one GP assistant training, and that can be nice for you guys to sort of share that learning and share tutorials and time and things as well.
you can absolutely support each other. You can absolutely, there's nothing wrong whatsoever with reflecting on things together. It's not formal mentorship, but if all of you have, if there's a problem that your practice has and all three of you have sat down to talk about it together, that's incredibly helpful, good practice. And that's something we also forget to say, is all this reflection is evidence for your portfolio. It's also incredibly powerful and useful for your own learning and for your own emotional well-being. It's not just a box we tick.
Thank you, Sarah. Great. That's the end of the questions that have been coming in so far. As I say, I'm happy to be contacted, and I'm sure there might be individual questions that many of you have. So if you do have questions or concerns that this has raised maybe, then feel free to send me an email. You've all got my email address, david.peachey@nhs.net. I'll be continuing to try and contact people over the next 6 weeks. The next week or two, I probably won't be trying to phone people just because it is very busy, but certainly into April I will be doing. And we'll also be sending over details to Cisco to get logins sorted, people set up on the course and things. And we'll also be getting this, what we've done over the last hour or so, as a recording to you all, again, which might take, it will, Bridie, the recording will be available. We're working out who's the best person to do it, because I'm not very technical at all. So someone who normally does it is just about to go on holiday for a week or two. So it might be a couple of weeks till the recording lands with you, but otherwise, somebody else who can assist us with that in the meantime. Otherwise, if there aren't any further questions, then thank you all for attending. I think this has certainly been our best attended launch event that we've ever had. So I'm hopeful that this is, and say, enjoy it. I think sometimes after an event like this, it can feel a bit daunting, but it's something to embrace and enjoy. So you know where I am, you know I'm not a scary being now, so you can contact me if there's any problems. Yes, thank you all for your time.